Welcome to BW Healthcare World. Today my guest is Dr. Umang Mathur, who is the Executive Director of Dr. Shroff's Charity Eye Hospital in New Delhi. He specializes in cornea, cataract, and LASIK surgery practices and has performed more than 20,000 surgeries to help people regain their vision and recover from eye conditions ranging from complex, complicated to the simple ones. He has also performed cataract eye surgery on the former President of India, Dr. Abdul Kalam, and to his credit is the establishment of the Eye Care Academy at SCEH, and also with the support of his team, he's running a very successful eye bank that is one of the leading eye banks in North India. Today, I'm going to be speaking to Dr. Mathur about the concept of tele-ophthalmology. Dr. Mathur, thank you so much for joining us on BW Healthcare World. My specific question to you is that telemedicine has been a boon during COVID and has become an integral part of how healthcare is now accessible at the grassroots levels. How has been the telemedicine journey in ophthalmology? Because this is where it is perceived that you need to be sitting in front of an ophthalmologist and get a test done.
Yeah, thank you so much for giving this opportunity. And you're right. Actually, as doctors, we have been slightly slow in adopting to technology that was already available. And generally, you would see a face-to-face kind of an interaction and bedside manners. And that is how you're taught medicine. And to be able to deliver medicine remotely was something that we had never experienced. And COVID basically forced us to do that. In fact, tele-ophthalmology, as it is called, we had been hearing about it, but quite frankly, even when we tested half-heartedly, we thought that, it's something just looks nice on paper, something that doesn't really work. But COVID times, we actually used tele-ophthalmology in 3 ways. And now we can see the power of it. First level, I would say, is patients who are seen at primary care. And at Shroff, and eye care is actually the community space, and eye care is very evolved. And we have a tiered system of healthcare. So at the bottom, we sometimes do screening door to door with some torch and some equipment and can identify. And actually, today there's an app by which you can note the vision. Then for a population of about 5,000 people, we open a vision center. And vision centers are manned by technicians who are trained over a 2-year period. And they can do refractions. They have a slit lamp to do basic eye examination, to identify diseases like cataract, to do pressure checks for glaucoma. And they know who requires urgent care, say corneal ulcers or infections and post-op care. And they can dispense glasses, so there's an optical outlet. All the patients who are identified were earlier sent to a surgical center, which is about 50 kilometers away. But even trivial complaints, because they don't have prescription rights. And so we didn't allow technicians to prescribe, because that becomes dangerous territory. You don't know what they can and what they can't. But during COVID, the government came out with a telemedicine policy, which allowed remote consultation. And so we integrated our vision centers with a camera, the slit lamp, where with a mobile phone, they could take a picture of the eye. And the electronic medical records that are available can be read remotely at the hospital. And so patients who have a pathology which a technician identifies, takes a picture, and here the doctor can see the history, the vision, and other parameters. Based on that, you can make a preliminary working diagnosis. And almost 60-70% of the patients that were earlier sent to the hospital now we are able to manage remotely. And a prescription can actually be given by the doctor with the registration number of the doctor, and the printout comes on the other side. And so this way you prevent those patients to travel the whole day to reach a doctor, and can give primary care at the grassroots level. And this has become the norm for us. Almost 3-4% of the patients going to the vision center are now getting a teleconsultation, what earlier used to come to the hospital. So I think you're able to give almost a tertiary care consultation at the primary care level. The second thing that happened was that a lot of our patients who were already into the system, sometimes you call them for various things, but they couldn't come because of COVID. So we were able to access that information through electronic medical records sitting at home. And with that record available, you know what was the diagnosis and how the patient is faring. And with a blurry, even if it's a little blurry picture that they take with a phone, we are able to get a working diagnosis of what's happening. And we realized a lot of our patients, we just call again and again just for assurance, that everything is okay. But if somebody can give you this information, and almost about 25% of the patients that you keep calling back can actually get a consult. So even in the city, a lot of these patients may not need to travel to a hospital where a doctor can consult and give preliminary diagnosis. So that also we saw the power of, and many hospitals now have a teleconsultation available. And of course, in medicine, a lot of COVID patients were treated that way. Then lastly, it is about training. We also do training for doctors and for paramedics. And we have hospitals across UP and Alwar where some of our younger doctors are posted, and also the paramedics that we train. And now, like I'm doing this consult with you on a Zoom, we do our classes regularly on Zoom. So you don't have to travel all the way for a 1 hour lecture. It can be done on Zoom or any of these platforms. And I think we've taken that, it's become the norm now that all our classes in the morning are also available on Zoom. And it's a reasonably good experience. A lot of our other, in medicine, the conferences that we have, a lot of those you can choose, and you don't waste time and money in travel. You can get the best speakers from across the world to speak without having to travel and host them, but you can consult with them. So all these things overall, I think in that sense, COVID has been a boon, that we've learned the power of this technology and how patients at the primary level to education of doctors can be done through this platform.
So, Dr. Mathur, what comes to our mind is that, like you rightly said, that COVID has been a boon in certain cases, and teleconsultation is definitely one of them. Where if you see that teleconsultations or telemedicine has been available for over a decade, it is not something which has just emerged after COVID. But one thing that has changed is that the adoption of this technology by both the doctors as well as the patients has gone up. But what is coming out right now is the innovation around technology to make it a better experience and better outcome. So one of the things that I see that, for example, artificial intelligence is playing a role, even in terms of one is artificial intelligence, second is the quality of the lenses, the microscopic lenses. So does this also impact tele-ophthalmology, where you can actually take the vision and this vision goes through the artificial intelligence to make it better?
Absolutely. I think there's a lot of scope, and I think ophthalmology probably offers the best scope, because we are very image dependent. and we can actually look into the eye, and it's the only place where you can actually see the blood vessels. You can see the back of the eye, and those blood vessels can also give you information about the rest of the body, about diabetes and hypertension and other things. So yes, there's a lot of work going on. Like, we use an app through which we can assess the vision on a mobile phone. So you don't need those charts and 6-meter distance. On a phone, it can actually calculate the distance and the light, and you can get up, and we validated it that the vision assessment that you can do at a doorstep can be done. In fact, the patient could even do it himself or herself. It's a free download from on the Play Store. So vision assessment, in fact, is the most important. I mean, you know what's happening to the eye based on vision itself. Then I think it's really, I think everybody's tried getting doctors right at the village level or even at the block level, but a doctor generally needs a lot of paraphernalia. And so a lot of those things have failed. Even right now, the government has opened up medical schools and district hospitals without looking at the quality of teaching and things. So it's a whole huge problem. At one level, I think everybody's trying. And across the world, even in the Western world, how do you access remote, how do remote patients access healthcare? And one of the ways to take care of that would be having technicians with technology. That if you have technicians who are trained, say for a year or so, and they get to have enough preliminary knowledge, and there's technology through which you get connected to higher centers, I think together they could take care of a lot of problems. Some happen there and some can happen remotely. So the lenses that are now available, in fact, if you see the new iPhone with that macro lens, can take a pretty good picture of the eye. And you can actually see what if there are deposits on the cornea, if there's a corneal ulcer, and a lot of those things can be done with those lenses. And also there's some cheap clip-on lenses by which you can get a decent image of the eye. And together with this information of vision and a picture of the eye, you can get pretty good information. There's also work happening, and these cameras used to be pretty expensive, the fundus cameras, about 35 lakhs or 40 lakhs. And so they were not easily accessible everywhere. But there are some Indian versions, and the price is coming down now, where you can take the picture of the back of the eye. So you can identify patients who have retinopathy because of diabetes. You can even send a technician. One of the newer problems that we are having is retinopathy of prematurity, where children who are born premature, they have to be screened. Their eyes have to be screened within the first few weeks. If you miss that window, a lot of them go blind. And if you pick them up at that stage, and those who need, you can do a laser, you can actually save a lot of them. But there's a small window, very small window. So you've got to go to NICUs and do screening there. So again, to send doctors to do that is tedious. But with this camera and a technician, they can screen who are normal, and only those who need to be seen by a doctor can be seen. So there are these interventions that are coming with technology that have big impact on public health and can be scaled up with paramedics and technology. So this is what we call as task shifting, that some things which were done only by doctors today can be done by a level below, and you get good outcomes. So, and you can be, in places where good healthcare is otherwise not available.
I think that's a very brilliant point that you brought up. Technicians empowered with technology can be a solution, or is now coming out to be a solution.
Yes.
So, Dr. Mathur, it has also been observed that in almost 88% of the blindness that we see is avoidable. Like you just mentioned about premature eye cases. However, the lack of infrastructure, medical personnel, or even awareness is delaying the timely treatment, and which could probably lead to permanent blindness.
Yeah.
Now, this issue is usually more prevalent in the rural areas, especially among the marginalized communities like scheduled castes, tribes, and minorities who may not have access to healthcare like we experience in the urban areas. How has been the infrastructure as well as medical personnel issue being addressed? Uh, Especially, and I'm taking a cue from your the last answer that technology with the technician could be a solution, but how does it actually see the light of the day?
Yeah, a very important question. If you look at healthcare, and it's not specific to eye care, I see one issue is of access, where there's a study by Sight Savers that says 75% of ophthalmologists are in 9 cities. So, probably Delhi NCR would have about 18 to 20%. And then there are districts, say in UP or Bihar, where there would be 1 or 2 doctors, or maybe some with none, with populations as large as 30 lakhs or so. Right? So access is an issue. Number 2 would be quality, where the consistency of outcomes is not there. So there are compromises, the quality of care, sterilization, follow-up care is missing. So there may be just numbers happening, but quality is missing. And so a surgery that you and I can access may not be available to a person in those areas. Then you have an issue of sustainability. How do you create models where you can reach out to the marginalized and the less fortunate? At the same time, you also have a system that is sustainable. You shouldn't just disappear. And the biggest problem is human healthcare workforce. And availability of health force in a region determines the quality of healthcare in that region. Now, we have found solutions to some of them by, especially for healthcare. If you ask most laymen, they would say, if you ask a question, who works in a hospital? And yes, everybody will say doctor. Probe a little more, they'll say a nurse. And that ends there. What we very recently, if at all, people are recognizing the role of allied health workers, where you can train technicians, say 12th pass people, into one kind of healthcare work. So we have been training young women, 12th pass, from in and around rural areas where we set up hospitals, and also lower socioeconomic group of Delhi. And in the last 6-7 years, we've trained 1,200 young women as eye care paramedics. And if you look at our hospitals in UP, almost 80% of the workforce is this paramedic workforce. So they can do refractions, history taking, pressure checks, registration, front office, assisting in OT. For example, it takes about 10 minutes to do a cataract surgery, but if I have just 2 assistants, I would do maybe 2 surgeries an hour, because one patient goes out, OT needs to be prepared, next trolley to be written, then the next patient comes. If I have 3 to 4 assistants, I can do even up to 4 or 5 surgeries an hour. So they just make the whole system so much more efficient. And like we talked about the vision centers, they can deliver primary care closer to where the patients are. So it improves your access, improves efficiency. And I see it as a dictum: anywhere you need to collect data, like your vision, your pressure check, or machines on which some test needs to be done, should be done by a technician. The doctor's role is to interpret that and to make a diagnosis. So otherwise, if the doctor starts doing that, you'll see only a handful of patients. So having paramedics really improves your efficiency that with paramedics around. Now, India is a strange country where you have more doctors than nurses or paramedics, while the ratio should be 1:4. So creating this health, and you can imagine you can create livelihoods. Healthcare can become, the biggest, and the need is also there of job creations in all these locations. With that, if you have some doctors and even young doctors, even if they're there, they can spend some time in some of these hospitals, you improve the healthcare in that region. With, of course, technology that we've spoken about. And you need very good quality assurance systems that monitor outcomes, monitor safety, monitor standards. There is no reason why a person living in a village should not get a safe surgery, as safe as a person living in, say, South Delhi. So putting proper quality assurance system. Now, in eye care, there are great models for of cross subsidy. The commonest cause of avoidable blindness is cataract, about 65%. Second commonest is refractive error, which is just, you need to get glasses. And diabetes and glaucoma, and these are corneal problems, are other issues. But if you look at cataract and refractive errors, irrespective of whether you're a rich person or a poor person, everybody gets it. Now that offers you models for cross subsidy. So you give high quality of care where patients who can pay for their surgery are able to pay for their surgery. And with that, we are able to cross subsidize and look after those who are less fortunate. In fact, in India, 70% of eye care is delivered outside the government hospitals, largely with these cross-subsidy models. And they are models which are now talked about across the world. India is at the forefront of this. A big benefit that we have is that India has a great consumable industry. We make our own lenses, sutures, and other materials that are required in surgery. That it's pretty unheard of that we can do a cataract surgery in less than $25. And so the incremental cost of surgery is just the consumable cost. In fact, a basic one can be done in less than 1,000 rupees. So whether I pay a nurse for 2 surgeries or 20 surgeries, my cost doesn't change. The only change is the consumable cost. And so I can do large volumes and still be viable. So if you look at your healthcare workforce creation, you look at quality assurance, you have a system of outreach so that you can reach those who have poor access through vision centers and secondary centers, and have a financially viable model, it is possible to take care of the avoidable blindness in the society.
Since we're talking about avoidable blindness or eye conditions in the society, now one of the areas we've spoken about, that rural areas and underserved areas have not had access to quality healthcare, not just ophthalmology, because the doctors weren't there, right?
Yeah.
And we did not have the technology in place to serve them remotely. But now with the tele-ophthalmology that is there and which is a reality, how do you deal with the problem of the lack of awareness in these areas?
So I would say one is the most critical is access. If you're available as a primary care or otherwise, any structure closer home, people will access. Because most people in India are daily wagers. Yeah, and they're older patients or pediatric or geriatric. That's the spectrum in eye care. Both you need somebody to accompany you. And so that person loses his daily wage. And because it's often a slow process, people just keep avoiding it. So if you have something closer home, people would access. That's the most important. But along with that, there is a need for improving the awareness in the society. And even those screening camps that people do, which today after COVID we've reduced, but I think one thing they definitely do is that they improve awareness about it. But I have seen, like, I'm a cornea specialist. We do a lot of eye banking also, and one of the complaints we've always had is that maybe Indians don't donate, and that actually is proven wrong. Most of the time, people don't know what has to be done. So when we put a grief counselor in a hospital where a death has taken place, and when you talk to the family, most, even the illiterate, agree to donate. But you have to make that connection. It has to be made convenient. You have to be there at the right place at the right time. So I think it is, yes, it's good if you have people knowing about it, your counseling and other efforts become easier. But at the same time, if you don't know what is the next step, you often find it very difficult. So improving access, I feel, is even more important than the awareness part of it.
Got it. I think that's a very brilliant point that you brought up, because when a tragedy happens in somebody's life, that's the last thing that is coming to their mind, unless somebody reaches there and reminds them that this is also.
That's correct. Even well-meaning people, it's happened to me as well. As I'm a cornea specialist, I do this day in, day out.
Right.
That when there's a death in the neighborhood or in the family, it's the next day you're saying, oh, missed an opportunity.
Yes, absolutely.
But if somebody is there and asks you, and then coordinates the whole thing, it takes only 20 minutes. The whole thing is done, and conveniently, most people would, say a yes to it.
Yes. So, Dr. Mathur, how is Dr. Shroff? You touched upon it briefly, but I want to really dig deeper into this. That how is Dr. Shroff working on imparting tele-ophthalmology medical training to the rural medical professionals, so that this can be not only accessible, but people start using it and adopting to the benefits of tele-ophthalmology?
Yeah, you've touched an important point, and I can't say we've really done a very good job of it, and it still needs to be improved. So we have only right now reached our own vision centers, trained the technicians to take the image, provided them with mobile phones and these lenses, and they've been able to do that. And also, the next steps, because how do you transfer images when the technology, the bandwidth is poor to transfer? And you like it or not, but we found WhatsApp is the best way of transferring images. When we have used other software, they're so heavy that sometimes the image doesn't get transferred. But it still hasn't gone beyond our own network. But it is, I think the next thing would be, like, if you go to villages and even remote areas, a lot of places there are these small optical shops. And one could, get in touch with them. And when they have pathology patients coming for just glasses and they find that vision is not improving, or somebody has some other red eye or something, we need to increase this whole network where when somebody needs help, they can access a doctor. So I think there's a lot of work to be done, but I think we've just touched a little bit right now, seen some success with it. But this needs to get amplified for more people to take benefit of it. So there's a lot of work still to be done. I think we've just kind of started doing.
Right. I agree. We've just scratched the surface, and now we have tested it, and now we need to scale it up.
Yes.
But Dr. Mathur, one of the things that is very imperative for the success of any such remote monitoring or remote consultations is the infrastructure. because like you just mentioned that this transfer of images itself is a challenge, right?
Yeah.
Uh, what, in your opinion, do you think is required? Does India have the required infrastructure to sustain teleophthalmology? And apart from just transferring the files, what are the other challenges that you face in making this a success? Something that where we need an improvement.
So it is improving, definitely. I mean, if you see even in remote locations today, I think the internet penetration has definitely improved. But very remote, I think we still have challenges, but it is improving. So it is something that, and smartphone penetration also has improved. So most of these technicians that we have, I mean, they are able to use that. So I'm optimistic that very soon, I mean, it should not be a huge big problem for this. But when it comes to software and things, when we use WhatsApp, one is this whole thing about confidentiality and of thing. Also, you lose data. It's in a very informal process. We would rather have all this data in a controlled manner where you can, have continuity of care of the patient. So right now it's very complex. Sometimes the image comes from a WhatsApp, then you transfer it into the electronic medical records and stuff. So the other issue is this whole thing about electronic medical records. It's still very few places that have it. And there's no standardization. Everybody is in that state of evolving into this EMR. Documentation in healthcare, in any case, in India is very poor. But electronic healthcare records, which the government is trying to, with the new policy, trying to have a centralized kind of healthcare records. I believe in blockchain is being used for that. I think those are steps that would help this whole movement. Because the patient should be empowered to have his own record. Right now, these are all pretty controlled by clinics and hospitals, if at all. The patients don't have access to their own health records. So these are newer challenges. I can see the government also working towards it. But it's right now very scattered, very fragmented. And in the private sector, everyone has their own system. So, and healthcare in any case is very dispersed. It's so these, I think there's a kind of opportunity there to integrate all these remote kind of methodologies, which are not so well trained medical practitioners practicing health medicine in some form that can get to some extent certified and brought into the mainstream kind of healthcare, because I think they do play a role. I mean, where the doctors are not there, it's we as doctors keep rubbishing all these medical practitioners, calling them quacks and things, but I think there's a little role there. What we don't have a system of certifying them, training them, giving them knowledge, because where the doctors are not there, somebody has to fill that gap.
I think that's a very valid point that you brought up. That there is an opportunity when we know that there's a gap between the number of doctors that we need versus what are available. And like you rightly said that wherever there's a doctor who's not present, somebody else is filling up a gap, and we call him a quack. So rather use the system to train them and acknowledge their
even the West. I mean, I learned that very late. Some of my visits to UK as well as in US, there is a system called nurse practitioner, where nurses are trained and certified and they're given prescription rights up to a certain level. Because and so they've created those triaging systems. We don't have that. So either you have doctors or you have nothing. I mean, they're just completely untrained people.
Correct. And the other broad point that you brought up, which is very, very important, is that while there are practices of different levels. So the more advanced ones, the larger ones adopted to EMRs. A little earlier on, the individual clinics still had those registers in which they
Yes,
would note down, but everybody had their own system and there was no exchange of data. you
that's
know
correct.
and so, for example, when a patient comes to you, you do not know his past history about hypertension,
That's
diabetes,
correct.
unless you diagnose and find out.
That's correct. It's
uh,
still like that. Yes. Yeah.
yeah, so I think that's where I think government is making a headway in terms of creating a universal platform, so that there's a collaborative approach to understanding the patient when he comes to you. uh,
Correct.
Now, Dr. Mathur, how has 2022 been for ophthalmology and eye care? What are some of the moments or advancements that we can talk of that can define the year 2022?
Yeah, it's been actually surprisingly very productive. And I think we bounced back from the COVID thing very strong. Maybe there was a lot of pent up demand because people postponed their surgeries. But most places grew by almost 30%. And I think we become more efficient because we learned all these tele-ophthalmology, we learned how a vision center can deliver, because the bigger cities like Delhi and Mumbai were more badly affected. Uh, and the remote locations where there was these vision centers, they were less affected. So you learned that you needed to create better access, and primary care was so important for that. Uh, and what can be done at a primary level need not come up to a hospital. So we created a lot of systems for that. I think the other thing which is coming up in a big way and would thank the government for that is Ayushman Bharat, where the government has created a wonderful platform. It's a whole digital system, almost like a insurance pathway. In fact, even better than the private insurance pathways, where uh, the bottom of the pyramid today has access to healthcare, and the hospitals finding it, it is much better for our sustainability, where you are getting reasonable reimbursement for taking care of the poor. And so it is no longer something that you're doing as a from philanthropic perspective. And the patient can also come with dignity. It's not looking for somebody's sympathy to look after. So and I unfortunately the census didn't happen because it's based on the 2011 census of who's in that BPL layer. You can question some of the things the way it has been dished out, but I think it's only improving. And so organizations like Shroff that otherwise also have a mission to look after the less fortunate, we are finding almost 15% of our patients today are accessing the Ayushman pathway. And we are more than happy to look after them. So I think that's something which is a game changer in healthcare. I can at least talk from even a hospital's perspective, not just the patient's perspective, that we have this opportunity to look after people and not worry so much about how we are going to give salaries to our employees.
Right. So, Dr. Mathur, we understand that 2022 has seen a comeback for the healthcare industry, and like you said, that in ophthalmology, it has been like a 30% growth. What do we expect in 2023 from both perspective of technology and advancement in the area of expertise or your field, and also in terms of the growth that we will expect in the industry? Do you see more players? Do you see some M&A activity? What is expected in 2020?
So at one level, you're seeing a lot of chains of ophthalmology clinics coming up, and there is you can see quite large funding that they are receiving. And so earlier they were largely concentrated in the metro cities, but now you can see that a lot of those chains of private clinics are reaching tier 2, tier 3 towns. So they're going to Darbhanga, they're going to Siliguri, and they're going to Gwalior and all these places. And improving to some extent the care and also the technology that is reaching there, from lasers to LASIK procedures and all, reaching those cities. But of course, they are trying to reach out to the top 5% of the population, but there is space there available, and you're seeing many chains of eye care hospitals coming up which have got funding for that purpose. So that's one thing that is happening. And on the other hand, you can also see that people are with the government's initiative on corporate social responsibility. Many corporates are looking at eye care as one of the areas that they want to support. And because eye care is one of the best investments in terms of what it brings in a change in the person and the productivity of an individual. So I think, and they're relatively simpler hospitals where there's risk of mortality is low and you have gratifying outcomes immediately. So the impact is very high. So I can see that there is interest in corporate social responsibility towards support of eye care. And hopefully that would allow better access through hospitals coming up in areas of need. And also some of the more evolved foundations are looking at how to create better human resource for eye care and supporting those initiatives, supporting surgical surgeries. So I think there's a movement towards it. And of course, our population is only increasing, and we're not increasing the pace at which we are opening hospitals and the way we are looking after the population. But India is doing a good job, I would say, overall, and especially in the eye care space.
So, Dr. Mathur, no amount of success in healthcare comes without the support of the policymakers in the country. So is there something which is your expectation as a representative of the ophthalmological industry that you have from the policymakers, which will help make eye care not only accessible but also affordable, quality eye care affordable for everyone? So what is your expectation from
So one, I would say, is healthcare infrastructure is expensive. So sometimes it is very daunting for a doctor or even a smaller clinic to initiate a nice eye care practice because the infrastructure is so expensive. So I think if there could be a much better way in which the government and the civil society can work together to improve healthcare infrastructure. And right now, it's otherwise one extreme of somebody at the higher end investing big time money, and the returns in healthcare are not that fast. So investors would also get very disappointed with the results that they want. And if you're very commercial, then you very often get too aggressive, which is not in the interest of the patient. In eye care specifically, I would say earlier the government did give a lot of concessions on import duty of equipment. So at one level, I would say the government needs to encourage Indian industry to make better medical equipment. And so there are some players, but I think they face stiff competition from things that come from the West or Japan and other places. And so they struggle with that. And if they need support to improve their quality and scale, I think that would be a game changer. Because I think Indian medical industry, I think, still needs to come up to that level. Consumables, they've done well, but in terms of more complex equipment, I think there needs to be a little push to have some of that come from our own, made in India label. I think there's still a lot of work to be done there. What we need to import with the duty is way too expensive. So earlier, the government had given a lot of support by reducing the import duty on medical equipment. Right now, with the import duty as well as GST, equipment has become, and with the way the dollar is moving up, equipment has become very expensive. And that again becomes a deterrent for people to be able to reach places that have more need. So they tend to work in big cities and hospitals which already have that equipment. So I think that would be another area that would be of help. And of course, there's better legislation for corneal eye donation that could help. That any death that takes place, there's a presumed consent, or there's a required request where everybody is required to ask for eye donation. So I think those would be areas where the government could definitely intervene.
And so what I hear from you is that GST and import duties, the two things, I mean, apart from the various things that you mentioned, are the two things which could be addressed by the budget of 2023. Yes. So apart from this, any other expectation from the budget that is going to help industry grow?
I think hospitals per se, fortunately, medicine is out of the GST gambit. So I hope it continues that way, and we don't have a service tax put onto that because it will make healthcare more expensive. So that would be one expectation. Equipment, like I said, if I would encourage Indian manufacturing. So what the government can do to support that, so that we don't have to import all kinds of specialized equipment. If you look at even radiology or those places, there's hardly any Indian company doing anything. And in eye care, we do have some players, but I think we need to have slightly better standards and quality, more consistency. I think if the government could support the industry to be able to invest in that kind of technology, that we are up there with the best in the world, I think that would be very useful.
And before I let you go, I would love to know, Dr. Mathur, that what is it that we could expect to see from Dr. Shroff's Eye Hospital in the next year or so? Is there some expansion plan that you have in mind?
Very much. In fact, we've just gone through our own strategic plan, and in the next 5 years, we want to reach 100,000 surgeries annually. We would be in more geographies where there's a need for eye care. From our side, we would like to be in UP area and around North India, but we would like to train more doctors, paramedics, so that there's a ripple effect wherever they go and they give good eye care. We would also be participating in a lot of research activities so that we improve the knowledge in the community. So there are big plans. We are very optimistic that in the next few years, we will be seeing almost double the number of patients that we are seeing and looking after surgically.
Awesome. Awesome. I wish you all the best, Dr. Mathur.
Thank you
And
so much.
thank you so much for taking out time to spend some time with us on BW Healthcare World. We look forward to many more conversations which are going to be useful for our audience as well. Thank you so much for
Thank you
your
so much. Enjoyed
time.
the conversation. Thank you so much.